Hey, healthcare friends, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you, written in your style and ready the moment the visit is over. All you have to do is give it to your patient. Just imagine leaving the office at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence cannot replace you, but it can do the administrative work that no human should be subjected to. Get back to doing what you love, helping your patients, and let Freed AI do the rest. Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out that free 31-page PDF. It's on the top 200 drugs. Great little study guide, refresher. Absolutely a no-brainer to have. Simply an email will get you access to that. So go take advantage of that. Share it with friends, colleagues, other students who are preparing for pharmacology. No problems at all there. All right, the drug of the day today is Benazepril. Brand name is Lotensin. A couple things to note here. There is a product called Lotensin HCT. That includes Benazepril and hydrochlorothiazide. There's also a product named Lotrel, which includes Benazepril and amlodipine. So we can take advantage of that sometimes using those combination medications where you get two medications in one pill, helps patient adherence and all that good stuff. But I want to caution you about getting these mixed up because that certainly can and does happen periodically. You've got to make sure you've got the correct medication, the correct medication combination that has been prescribed for, or if you're doing the prescribing, making sure you're selecting the right one and not the combination if you didn't want it. So pay attention to that. Really, really important. Along that vein, this is an antihypertensive medication. Being an ACE inhibitor, that makes sense. I'm going to focus primarily on Benazepril. However, with that combination therapy, I wanted to point this out. Some clinicians will elect to jump straight to combination therapy where we prescribe two blood pressure medications at the same time. Typically going to be at lower dosages because you don't want to overdo it with a patient and cause too many adverse effects there. But in patients who are typically have much more significantly elevated blood pressure, let's say over 20 systolic or over 10 diastolic above where we want them to be, that's a situation where some clinicians are going to elect to choose combination therapy over starting just one medication. Okay, so if you do that, make sure that you know the medication you're utilizing, understand the dosages, that sort of thing, and obviously educate that patient on both those medications as well. Benazepril, from a mechanism of action standpoint, it inhibits angiotensin converting enzyme, which ultimately results in less angiotensin II. So, again, kind of summing this up, it's a competitive inhibition of angiotensin II being converted to angiotensin 1 being converted to angiotensin 2 causing that vasoconstriction. So we reduce the amount of angiotensin 2. This ultimately also reduces the amount of aldosterone secretion. So what does aldosterone do? Aldosterone stimulates the kidneys to reabsorb sodium and reabsorb water from the urine back into the body. Okay? And ultimately, if we have that reabsorption of water, sodium, that's going to increase blood volume and increase blood pressure. So kind of a couple of things there that ACE inhibitors can do in general. Dosing of this medication, standard dosing, I would say I see in the range of 10 to 40 milligrams per day, usually given once daily. Reassess every 2 to 4 weeks, obviously tracking blood pressure as well as some lab work, which I'll talk about coming up here. But again, kind of in that 2 to 4 week range. When I was working in an ambulatory care clinic, we'd typically target that 2-week range. If it didn't work with the patient's schedule, that type of thing, then maybe we'd put that a little further out. But the 2 to 4 week range is kind of a good target to follow up with patients there. So in the vein of dosing, so to speak, the half-life of the original compound is 10 to 11 hours. However, the active metabolite is up to 22 hours, or in the range of 22 hours. So typically with Benazepril, I've only seen it once daily, but I believe if you go look at the package insert or look at some other information on prescribing the medication, it can say, give up to 40 milligrams in divided doses. So you may see it twice a day as well. And if you have a patient that's, maybe they're having, trouble managing their blood pressure later in the day, or it spikes at certain times of the day or something, maybe that's a situation where clinically we look at that and then we end up splitting up that dose. A couple things to note as far as dosing and potentially starting a little bit more conservatively. So in the patient population I work with, you might start a little bit more conservatively, maybe a 5 milligram starting dose rather than 10. So older age, worse renal function. If you've got a patient that's really sensitive to hypotension or falls, maybe somebody that's, got kind of borderline hyperkalemic, that might be a little situation where we're going to be a little bit more cautious about, causing that hyperkalemia to get worse there. Adverse effect profile, so that's the first one I'll mention, is elevations in potassium can happen, so that's why we draw that lab. AKI, acute kidney injury, can happen, not incredibly common, but that can happen, so we monitor that renal function as well, typically at that 2 to 4 week follow-up. Cough can happen with ACE inhibitors, of course. I've seen numerous cases in my practice where, patient goes to a pharmacy, gets an over-the-counter cough syrup, they're taking it for weeks on end periodically, and they don't recognize that it could be a potential adverse effect from a medication like Benazepril. So if you see patients, asking for cough syrup, complaining about a chronic cough, that should be the first place to look, is that medication list. Make sure they have not started on an ACE inhibitor. Angioedema, very, very rare, but very, very serious reaction to ACE inhibitors. Swelling of the lips, tongue, and throat can happen. Obviously, can cut off the airway if it gets severe enough. Definitely something you're going to want to pay attention to, educate patients on. And then that AKI risk, again, not incredibly common, but there are patients that may be at higher risk. Older age, pre-existing renal dysfunction or renal issues, patients with heart failure, patients on certain other medications, and I'll mention that in the drug interaction section a little bit further. But again, those are some of the risk factors, common risk factors that I see that may increase that risk for that drop in creatinine clearance and AKI type situation. And then, of course, we're using Benazepril to lower blood pressure, and we can lower it too far. So increasing the risk of dizziness, falls, orthostasis, those type of things. One adverse effect that does come up with antihypertensive medications is sexual impairment. ACE inhibitors are typically better than diuretics, beta blockers, for example, in that they typically don't cause as much sexual impairment compared to those other classes. So definitely something I've seen come up on pharmacology and board exams periodically. Compelling indications with ACE inhibitors, very, very important to recognize. Obviously, primary use is going to be hypertension, but we have seen some beneficial effects in diabetes, CKD, stroke, CHF, and MI as well. Monitoring, lab work, kidney function I alluded to, potassium we talked about a little bit. Keep an eye on the creatinine. So if that increases by more than typically 30%, That's a little bit more concerning as far as that ACE inhibitor maybe worsening their renal function rather than potentially help preserving it. One last warning, absolutely got to know this, definitely going to come up on a board exam, pharmacology exam throughout your career. ACE inhibitors like Benazepril and ARBs, they have a boxed warning for fetal toxicity in pregnancy. So definitely one to know there for sure. One controversial thing that's, we've kind of got some evolving evidence over the last 5-10 years here. So historically, there has been some evidence that ACE inhibitors like Benazepril are less effective in black patients, but now we potentially have some evidence saying, that they work just fine, particularly if you're using them in combination with other agents. So, jury's still a little bit out maybe on that. With that said, I think most clinicians I've talked to, and from what I've seen, most clinicians are fairly comfortable using ACE inhibitors in black patients, but is just something to note. And obviously, we can monitor them clinically. Did they respond? Did this medication lower their blood pressure? Are they having any issues? Those type of things as well. So again, jury's maybe still a little bit of a question mark. Jury's still out on that one a little bit, but I did want to mention that. All right, let's take a quick break from our sponsor, and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, NAPLEX, BCMTMS, go check out meded101.com/store. We've got a growing list of resources there, have helped thousands pass their board exam, and we can absolutely help you too. If you're a nurse, med student, other healthcare professional, we got books for you as well on case studies, drug interactions, clinical pearls relating to medications. Got a nursing pharmacology study guide on Amazon. Lots of different things for you to check out. So go support the sponsor, take a look, everything we have, meded101.com/store. All right, finishing up with drug interactions. First one I want to mention is hyperkalemia. So ACE inhibitors, Benazepril by itself can raise potassium levels, but we have a few drugs that are commonly used that may increase that risk. So trimethoprim, antibiotic for infection, often in the combination of Bactrim with sulfamethoxazole. Trimethoprim absolutely can raise potassium levels. I have seen an ER case regarding this, somebody who had a borderline high potassium, started trimethoprim already on an ACE inhibitor, and they ended up with an emergency elevation in their potassium level. So pay attention to that for sure. Potassium supplements, pay attention to those as well. Many times in practice, I've seen, let's say, a loop diuretic. Maybe a patient's having some acute edema going on. We get a loop diuretic on board, 2 to 4 weeks. It resolves. But in the meantime, because that furosemide drops potassium, we had to add a potassium supplement. So furosemide gets stopped, edema's resolved, and the provider just kind of spaces out, forgets that they prescribed that potassium supplement too. Now they're on a potassium supplement, and maybe an ACE inhibitor is added on top of that, and we can end up putting that patient into a hyperkalemic state. The last one I'll mention, spironolactone, relatively commonly used for hypertension. You may see it for ascites, you may see it in heart failure. But this medication on its own can raise potassium levels. It's called a potassium-sparing diuretic for a reason. But in combination with an ACE inhibitor, those potassium levels may go even higher. AKI, so acute kidney injury. Keep tabs on diuretic use. The more and more diuretics we use with a patient on an ACE inhibitor, that may increase that risk for AKI. The other med class that's commonly used is NSAIDs. You got an NSAID on top of an ACE inhibitor and in combination with a diuretic. That's kind of the trifecta where it can significantly cause some issues with the kidney and definitely increase the risk for acute kidney injury. So close monitoring of renal function, creatinine clearance, eGFR, those type of things with dose increases and new starts of any of these medications. Blood pressure lowering meds, I think that's kind of common sense. We're trying to lower blood pressure with Benazepril. Drugs like Sinemet, PDE5 inhibitors like sildenafil or brand name Viagra. These can lower blood pressure as well. So pay attention to that. We don't want it to get too low and they get dizzy and fall risk and all that nasty stuff there too. So again, pay attention to that. On the flip side, we've got medications that can oppose blood pressure lowering effects of Benazepril. Stimulants come to mind. So those drugs for ADHD, for example, methylphenidate, amphetamine derivatives. Another medication I just covered, previous podcast, is modafinil. So that's a stimulant-type medication, can raise blood pressure. NSAIDs can cause some sodium retention, can raise blood pressure as well. So definitely important to remember some of those. Last but not least, I do want to mention lithium for bipolar disorder. When we add Benazepril, the effects in the kidney can ultimately increase the concentrations of lithium in the blood. Lithium is one of those narrow therapeutic index drugs where there's a really fine line between an effective dose, toxic dose, and a subtherapeutic dose. So really, really important. If we add Benazepril, feel like we need to use that medication or an ACE inhibitor in general, if we need that medication class, you've got to recognize that it may alter the lithium levels if you've got a bipolar patient. So make sure we're aware of that. Make sure we're, monitoring the patient clinically, making sure we're not inducing lithium toxicity. And B, we can check levels. We can check lithium levels, look at where their baseline was at, and then, potentially after we added the Benazepril, we can check those lithium levels again, and make sure that it didn't spike too much or cause any issues there. All right, well, that's going to wrap up the podcast for today. Thank you so much for listening. Do me a huge favor. Support the sponsor, med101.com/store. Also, leave a rating review on iTunes or whatever platform you're listening on. I greatly appreciate that. And, of course, share us. Friends, colleagues, other pharmacy students, med students, nursing students who need pharmacology help. Definitely share the podcast. Recognize we have covered well over 300 individual drugs, and we've got the top 200 list that's been completed as well. Go take advantage of all those episodes. Learn some pharmacology while you're going for a walk, exercising, flying on a plane, driving, whatever the case may be. Go pick up a few practice pearls, learn a little bit more about pharmacology. I greatly appreciate you sharing it. If you got any comments, suggestions, mededucation101@gmail.com, or you can connect with me on LinkedIn as well. Eric Christensen, PharmD, BCPS, BCGP. Thank you so much for listening. Take care, and I hope you have a great rest of your day.